This is a message for the Ohio Physical Therapy Association, prepared by the Imaging Special Interest Group of the Orthopedic Section of the APTA. Diagnostic Imaging Privileges for Physical Therapists. One step in value-driven healthcare. First, let's consider that physical therapists having referral for diagnostic imaging privileges is an accepted model of practice internationally. In at least 3 provinces of Canada, as well as the United Kingdom, Norway, the Netherlands, South Africa, and Australia, physiotherapists have imaging privileges to some degree. Physical therapists having imaging privileges also has precedent in the U.S. The military model of physical therapist practice has included imaging privileges for greater than 4 decades. Other federal and civil service institutions have similar practice models. In some large institutional settings, such as Georgetown University Hospital, Kaiser Permanente in California, the University of Wisconsin Hospital and Clinics, and my physical therapist in practitioners in Colorado. Quite simply, this model of practice works, and has been documented to do so for many years. In the military, dating back to evidence published in 1975, patients managed by physical therapists with imaging privileges on primary contact had far fewer radiographs completed compared to those patients managed by physicians, and these patients were successfully managed in a conservative manner. The quality of care was found to be acceptable to all parties involved. In the United Kingdom's National Health Service, a study assessed patients initially evaluated by orthopedically trained physiotherapists to those first seen by physicians. Those patients managed by physiotherapists had greater patient satisfaction, lower direct hospital costs, 3 times fewer radiographs, and dramatically fewer orthopedic surgery referrals because of successful diagnosis and treatment by the physiotherapist. To clarify, this is not to imply physical therapists should function as radiologists, but rather to more directly work in a cooperative manner with radiologists to achieve the best possible health care for consumers. The role of the physical therapist is more to understand and act on how imaging integrates with our initial medical screening processes, as well as our routine everyday clinical decision-making processes, to more accurately and efficiently provide care. Physical therapists having imaging privileges can also make for greater value-driven health care to benefit the consumer. Delays in diagnosis and determination of the eventual preferred course of care has been cited by consumers as a key area of dissatisfaction in healthcare delivery. Consistent with the dissatisfaction of consumers, the Institute of Medicine has cited that making the diagnostic process more efficient should be a priority in improving healthcare delivery. Physical therapy educational curricula are required by accreditation standards to teach diagnostic imaging to future practitioners, and most have been doing so for many years. In support of this, the Imaging Special Interest Group of the Orthopedic Section of the APTA published 2 years ago a guide for PT educational programs and how to best integrate imaging into their curricula and to produce knowledgeable future practitioners. To be clear, physical therapy curricula do not teach imaging typically in the same way that future physicians are taught the technical aspects of imaging. Rather, clinical reasoning inclusive of imaging to advance the diagnostic process when informative is the focus of physical therapy educational programs. If one looks at the most comprehensive and accepted set of imaging guidelines in the U.S., the American College of Radiology Appropriateness Criteria, the items used to determine whether imaging is indicated in patient care and the type of imaging are all elements of patient data that physical therapists have gathered for decades. information on the patient's age, whether trauma has occurred or not, the mechanism of injury, prior surgery, specific risk factors, the appearance of the patient's anatomy, the results of physical function and pain provocation test, other prior imaging results, the ability to weight bear, and tenderness to palpation are all well within the scope of physical therapist practice and part of everyday decision-making for physical therapists. Thus, why not use this decision-making for imaging too? There is evolving legislative authority across the country in several jurisdictions. In the spring of 2016, Wisconsin Governor Scott Walker signed into law Wisconsin Act 375, which specifically included physical therapists as among the healthcare providers with privileges to refer patients for radiography. Other states, such as Colorado, Maryland, and New Jersey, have physical therapy practice acts interpretable to include referral for diagnostic imaging. Toward these expanded privileges, the Imaging Special Interest Group of the Orthopedic Section of the APTA published a white paper last year on imaging in physical therapist practice. This not only provides a historical perspective of imaging in physical therapist practice, but also describes how healthcare can be improved by physical therapists having imaging privileges. Can physical therapists successfully use consensus-derived imaging guidelines? The evidence says yes. As described earlier, some of this evidence has existed for many years, such as the Springer et al. Study of 2000. In this study, physical therapists and orthopedic surgeons were found to have equivalent competencies in application of the Ottawa ankle and foot rules to identify those in need of foot and ankle imaging for possible fractures. More recently, a retrospective review of patients referred for advanced imaging by physical therapists in a direct access setting revealed that greater than 83% of those referred had American College of Radiology appropriateness criteria ratings of equal to or greater than 7, meaning the patients were, indeed, usually appropriate for advanced imaging procedures. Further, 90% of the physical therapist's clinical diagnoses were confirmed upon surgical exposure for those patients eventually needing surgery. The end result of this evidence confirms that physical therapists are capable of patient management decisions, including whose care may benefit from imaging and, just as importantly, those who may not warrant imaging. The end result of physical therapists having imaging privileges is medical screening and first contact care for those patients with musculoskeletal disorders can be improved. Patient safety can be increased, and greater quality of care delivered. For the consumer, more efficient and timely delivery of care, along with potential cost savings. The bottom line is that for those patients with musculoskeletal disorders who can best conduct and interpret the clinical examination, and from that determine who may or may not benefit from imaging, who can best integrate those imaging results into clinical decision-making, and who can best deliver the care. The answer to all of these questions is a physical therapist with imaging privileges.